good afternoon, or as it may be, good morning and or good evening. It's my great pleasure to welcome you at this Qatar Symposium, the fifth Qatar Symposium devoted to epidemiology and racism. This is a symposium in the tradition of the Qatar Lectures, which have been held since 1912 in the Harvard School of Public Health under the auspices given by Clarence Qatar, and they're hosted by the Department of Epidemiology. My name is Bert Hofman. I'm the chair of the Department of Epidemiology. I will introduce the three speakers that we have in this hour, in this symposium, separately, and therefore I start with Dr. David Williams. Dr. Williams is the Florence Sprague Norman and Laura Smart Norman Professor of Public Health. He is the chair of the Department of Social and Behavioral Sciences of Harvard Chan, and he is an internationally renowned, recognized scientist on the influence of social effects, social influence on health. David, it's wonderful to have you in this symposium, and I'm happy to give you the floor to speak on COVID-19. Can it be more appropriate? COVID-19, a tutorial on racism. Dr. Williams.
Thank you so very much. And it's really good to be here today on this special symposium and the lecture later today with my friend, colleague, and one of my public health heroes, Sherman James. I'm going to share my screen and go to my presentation. COVID-19, a tutorial on racism. What I want to do is to give you an overview, high-level overview of the ways in which racism operates within society and the multiple mechanisms by which it can harm health. I begin with the pandemic. Deaths from COVID-19, age-adjusted odds ratios here, and you can see that the indigenous, the Latino, the Black, and the Pacific Islander population all have death rates from COVID-19 that are twice as high compared to those of whites. These are the actual numbers. Almost 300,000 whites have died from COVID-19. This was deaths through March 2, compared to about 89,000 Latinos and 73,000 African Americans. This large impact of COVID-19 has affected even the life expectancy rates in the United States. This is a report from NCHS that showed, if you looked at the first 6 months of 2020 compared to 2019, all of the major racial groups have experienced some decline in life expectancy, ranging from a 3-year decline for African American males to 0.7 of a year decline for white females. If I look across the Atlantic and look at data from the United Kingdom, I also see that men in the United Kingdom, Black men, Bangladeshi, Pakistani, and Indian men have markedly elevated death rates compared to those of the white population. And if we look at the data for women, we see another pattern. So I'm showing you across two societies, we are seeing very striking the age-adjusted odds ratios for deaths in the United Kingdom compared to the white population there. So what drives these racial inequities in health? Well, I would begin by thinking that there are large inequities in health by socioeconomic status in the US and elsewhere. And in fact, there are large racial ethnic differences in socioeconomic status. This is median household income in the United States by race in the year 2018. And I'll just put this in a way where you can't miss the point. I'm standardizing on the income of whites as $1 and looking at how other groups compare to the income of whites. Asian households have $1.23. Keep in mind that Asian households, the Asian category is heavily made up of immigrants. Almost 70% are immigrants. They've come to the United States with high levels of education. So that's one factor. Another important factor to keep in mind is that Asian households on average have more persons contributing to household income than any other groups. If there was a per capita measure of income, whites would have the highest. But let's look at the historically disadvantaged groups. For every dollar of household income white households receive, Latino households receive 73 cents, and Native American and Black households receive 59 cents. What is striking about the 59 cents figure for Blacks is that is identical to the Black-white gap in income in 1978. You heard me correct. I did not misspeak. 1978, the peak year of the narrowing of the Black-white gap in income as a result of the civil rights policies and the anti-poverty policies of the 60s and 70s. It was reduced to 59 cents. And in 2018, it is still 59 cents. If I look across, go to the United Kingdom, for every pound of weekly income the white majority earns, we see other groups also earn less income. Other whites, mainly European whites, Eastern European whites, 79p, Indians, 86p, Pakistanis, 57, Bangladeshi, 52, Chinese, 76, Black Caribbean, 77, Black Africans, 60p. So we see across two societies, the racial ethnic status is linked to economic status. Looking at data on income markedly understates the racial gaps in economic status. Because income tells us about the flow of resources into the household, it does not tell us about the economic reserves that households have to cushion shortfalls of income. We get that from data on wealth. And for every dollar of wealth that white households have, Black households have 10 cents and Latino households have 12 cents. And if we look in the United Kingdom, we see a similar pattern of standardizing on the white British of £1. Indians have 95 pence, but you can see Pakistani with 50p, Blacks from the Caribbean 20p, and 10p for Blacks from Africa and Bangladeshis. So across two societies, we see the racial category tells us something profound about economic status. However, what we have, the data has told us is that the racial ethnic gaps in health are not simply a function of income and education and wealth, but there is an added burden of race. I will illustrate that with US data, life expectancy at age 25, national data for the United States, by level of education, there's a 5-year racial gap. By education, from whites with a college degree or more education to whites who have not finished high school, there's a 6.4-year gap. And again, within African Americans, there's a 5.3-year gap. So the socioeconomic gaps within each race are larger than the overall racial gaps. At the same time, at every level of education and income, I'm only showing you the education data, but it's true also for income, race still matters. So white high school dropouts live 3.1 years longer than Black high school dropouts. And that gap widens as education increases, with this stunning stat here, that the best off African Americans, those with a college degree or more education, have lower life expectancy than whites with a college degree, than whites with some college education, than whites who have finished high school. So there's something about income and education that matter for your health, regardless of race, but there's something else about race that matters profoundly for your health, even after you've taken income and education into account. If we look at the COVID-19 data for the United Kingdom, we see a similar pattern. These were the age-adjusted COVID deaths for the different racial groups compared to whites. And after adjusting for multiple indicators of socioeconomic status and urbanicity and household tenure and so forth, we still see the persistence of an effect of race for men as well as for women in the United Kingdom. So across two societies, we see a residual effect of race. And so researchers have been asking the question, could racism be a critical missing piece of the puzzle to understand the patterning of racial disparities in health? And when I say racism, I'm talking primarily about the societal system that interacts with other major factors within society that categorizes and ranks population groups and differentially allocates opportunities and resources to those groups. It's premised on an ideology of inferiority, and at an individual level, you can see prejudice and stereotypes, and you can see differential treatment, that is discrimination, by both individuals and institutions. So I want to talk about an upstream mechanism of racism, institutional, structural, or systemic are terms used in the literature. And I want to talk specifically in the US context about residential segregation. That was where you could live was linked to based on your race. It's a powerful predictor of outcomes in American society. Here's a book about the history of segregation that argues it was one of the most successful domestic policies of the 20th century in the United States. Think of segregation as a toxic emission that shows up in a community, and it may be imperceptible, but as segregation shows up, valuable resources disappear. Things like quality schools and safe playgrounds and good jobs and healthy air and water and safe housing and transportation. All of these factors and healthcare vary by segregation level in the US. Let's look at some empirical data. Two of America's eminent sociologists from across the river, William Julius Wilson and Robert Sampson, studied 171 largest cities in the United States and said there's not even one city where whites live under equal conditions to those of blacks, and that the worst urban context in which whites reside is considerably better than the average context of black communities. More recently, Dolores Acevedo Garcia from Brandeis has created a index of neighborhood opportunity that has 29 indicators in 5 different categories. There are examples of those categories here. And what she shows, in the 100 largest metropolitan areas in the US, 2/3 of all black children are living in very low or low opportunity neighborhoods. That's also true of 58% of Latino kids, 53% of Native American kids, but only about 1 in 5 white and Asian kids. On the other hand, who lives in high and very high opportunity neighborhoods? Almost 2/3 of white and Asian kids, compared to 1 in 5 of Latino and African American kids. So segregation is also a central driver of even the differences in economic status that I showed you earlier. Here is David Cutler, an economist here at Harvard University, using national data for the United States, statistically shows if you could eliminate residential segregation, you would completely erase black-white differences in income, in education, and in unemployment, and black-white differences in single motherhood by 2/3. All of those differences are driven by opportunity at the neighborhood level. More recently, another Harvard economist, Rash Shetty, a paper published just last year, did an intergenerational analysis looking at black and white children, statistically controlling on parental income, and looking at how they are doing in the next generation. And in 99% of census tracts in America, black boys will earn less income than their white counterparts, even after we took their beginning income into account. Why? They live in neighborhoods that differ in access to opportunity. In Europe, we also have high levels of segregation, although they are increasing, I should say. They are increasing in Europe while they're declining in the US. And religion plays an important role, with Muslims being heavily segregated. Here, the segregation levels in the United Kingdom, Bangladeshis and Pakistanis, 2 of the disadvantaged groups, reflecting the highest levels of segregation. Another way to think of the clustering of deprivation is the percentage of different ethnic groups in the UK living in the 10% of most deprived neighborhoods. And you can see the overrepresentation of these disadvantaged populations: Pakistani, Black, Bangladeshis, Africans, Black Caribbeans, and Arabs, all overrepresented in deprived areas. What does the mechanism of segregation and other mechanisms in the UK that might have collaborated with it producing? What we see then is the racial inequities in SES that matter for life and health do not reflect a broken system. Instead, they reflect a carefully crafted system, functioning as planned, successfully implementing social policies, many of which are rooted in racism. They reflect the extent to which racism has produced a truly rigged system in the United States. And low economic status means that even though we are in the same storm of the pandemic, when you are low in economic status, you're in a boat that is not as prepared to weather the storm. And when you live in a highly segregated community with disadvantaged segregated areas and low in economic status, you have higher levels of economic, psychosocial, and physical stress. We haven't paid much attention to the chemical stresses, but air pollution is a risk factor for the severity of COVID-19, for example. And this is an institutional mechanism of racism. There's also racism at the individual level. The experiences of discrimination, subjective experiences, an added source of toxic stress. Here is a measure that I developed, just capturing some aspects of discrimination, just little indignities being treated with less courtesy and less respect. Studies reveal that everyday discrimination predicts incident, metabolic syndrome, cardiovascular outcomes, breast cancer, type 2 diabetes, a broad range of risk factors for heart disease, a broad range of subclinical indicators of heart disease, hypertension, sleep duration and quality, inflammation, cortisol level, obesity level, utilization of healthcare services, and mental health. So a broad range of risk factors are created by these constant assaults to Black dignity and Black hope that discrimination captures. And then there are hidden ways in which stressors linked to race and racism also adversely affect health. This is an example of a study shows online discrimination adversely affecting the health of adolescents. Viewing traumatic videos of someone from your race being abused by the police adversely affecting teenagers' health. Police stops adversely affecting the health of the mothers who were the parents of those kids. And one final study that's looking at these effects that documents that every police killing of an unarmed Black male leads to worse mental health for the entire Black population in the state in which it occurred for the next 3 months. And all of these processes lead to what researchers are calling accelerated aging or premature aging or weathering. Is the earlier onset of chronic disease as evidenced in blood pressure. In addition to that, there is the racism in the culture, which leads to inequities in access to medical care. And there's a study that shows these inequities are quite large. Let me wrap up here and talk about what can we do. What can we do? We need to diversify the workforce to meet the needs of all patients. There's a study, a randomized controlled trial that shows when Black men are treated by Black physicians, the quality of care is in fact a lot better. What else can we do? We need to create communities of opportunity to neutralize the systems of racism that is attendant to neighborhood quality and housing quality. And there are a number of strategies here that have been shown to be effective by improving economic circumstances. We can improve the quality of life for individuals. I leave you with the words of Martin Luther King. True compassion is more than flinging a coin to a beggar. It understands that an edifice which produces beggars needs restructuring. And racism is one of those edifices that need restructuring. Thank you very much.
Dr. Williams, thank you very much. This was an impressive presentation with indeed impressive evidence. May I congratulate you and thank you. There is the opportunity, I think, David, you give us to ask one or two questions that are, yes?
Sure. Yes.
I have one question in the Q&A. I probably it's best when I specify it, although if there is a person who wants to say this, Coppelia, is that possible as well, or should I read it? I read it. Has there been consideration of hidden disparities due to lack of disaggregated data, especially among Pacific Islanders, Lao, and other populations that are lumped to in the big group of Asian?
That is absolutely correct. The issue of the heterogeneity of populations applies to all racial categories. There's heterogeneity within the white category, within the Black category, within the Latino category, within the Asian category, with the Native, within every category, there is heterogeneity. And just to illustrate the point, within the Asian category with the highest levels of income, there are subgroups of Asians, the Hmong, the Laotian, and the Cambodians that have lower levels of income than African Americans and Native Americans. So yes, there is heterogeneity, but it's not restricted to that group. It literally applies to every group.
Thank you. David, you said what to do, you focus on the workforce and on communities. I can very well understand. What about education?
Yes, so I'm talking about place-based initiatives that would include improving the quality of schools. So yes, education is one component of that. And there is very impressive evidence from early childhood programs like the Abecedarian Project in North Carolina that where poor children at birth were randomized to receive an early childhood intervention project where they went to a center and got good nutrition and good access to medical care and good intellectual stimulation. By age 35, this is birth through 5, they got this. By age 35, they not only have done better educationally and in income, but they also have markedly lower levels of obesity and of a broad range of risk factors for cardiovascular disease linked to the intervention they receive birth through 5. So yes, education at all levels, but even starting early is the evidence is quite strong on.
Thank you very, very much. Very impressive. We have a strict schedule, so we go now to our David. Thank you very much, Sam. We go to our next speaker. Wonderful to have our colleague from the Harvard Kennedy School, Dr. Will Dobby, professor of public policy, and his research focuses on the causes and consequences of poverty in the US. Dr. Dobby, be welcome in the Harvard T.H. Chan School of Public Health. It's one Harvard, and it's my great pleasure to give you the floor.
Well, thank you so much for having me, and it's a pleasure to be here. So I'm going to zoom in on another part of the American system where we also see just enormous racial disparities and disparate treatment of different groups, really building on what Professor Williams discussed. Now, within the criminal justice system, you see that the US is a true outlier in many respects. Now, here I'm just zooming in on one piece of the criminal justice system, which is what happens before trial. Now, in the US, after you're arrested, you usually come before a bail judge or magistrate who determines whether you're going to be released before trial or whether you need to be detained, oftentimes up to months or even years before the trial occurs and you're ever convicted of a crime. Now, what we see in this graph is that the US has nearly twice as many people detained as any other country in the OECD. Now, it's not just that we have these very high pretrial detention rates in general. To go along with our high rates of incarceration after trial is that there's tremendous heterogeneity both across place and across groups within place. Again, echoing many of the themes that Professor Williams talked about. So on the left, you'll see that we have many places in the country that detain over 50% of the people charged with a crime in their jurisdiction. So places like Harris County, Texas, or Orange County, California, detain the majority of people who are accused of a crime without them ever being convicted. Now, many of those same places also have incredibly high differences in the rate that white and minority individuals are detained. So again, you'll see many of the same types of names like Orange County, California, and Harris County, Texas, where minority individuals are just detained at much, much higher rates, even after we condition on the type of charge that is involved or any type of prior criminal history. And so these are just unexplained differences in how minorities and whites are treated within these courts. Now, not only is this terrible because people have not been convicted of a crime, we think there are very important consequences of the criminal justice system and pretrial detention specifically. And we see this both in the qualitative work that many folks have done, as well as in the quantitative work that I've focused on. So this is the type of story that we very often hear from the court system, where individuals who are detained before trial often will lose their job because they're gone for just a few days, or perhaps they'll lose their home because they're not showing up for their curfews. Similar concerns with immigration or kids and so on. Now, this ends up being confirmed in the quantitative data that we have access to. So along with my colleagues, we've looked at what happens if you're detained for just a few days when we zoom out many years down the road. And what we see is that people are far less likely to be employed, far more likely to be in economic distress, again, even just after a short couple of days stay in jail. Now, of course, we want to understand, are these racial disparities and these disproportionate effects of the pretrial system due to judges treating people differently? Or is this because of all the other disadvantage that's built in from the systemic racism that, again, Professor Williams highlighted so well? Now here, in answering those types of questions, we're aided by the fact that in the pretrial system, judges have a very narrow legal goal. Their goal is to minimize pretrial misconduct, which you can think of as new crimes that are committed before a trial concludes, while releasing as many people as possible. That means that if judges are treating white and black individuals in exactly the same way, if they have the same cutoff for who they release and who they detain, we should expect that last set of white individuals and that last set of black individuals to be of similar risk. So they should have the same rates of pretrial misconduct when they're actually released. Now, using the econometric tools that we've developed in economics, we can actually isolate this last set of individuals and ask the simple question, well, what is happening among that last set of white and Black individuals who are released by judges? Now, this graph summarizes what we found. In short, the last set of white individuals that are released still are quite high risk. About 25% go on to commit some form of new crime, with property crime being a little under 20%, drug crime being around 8%, and violent crime also being around 8 or 9%. Now, that's not inherently bad. It could be that we want a relatively lenient system, but where the problem really emerges is what happens when we look at that last set of Black individuals released. And here we see that in each case for each type of crime, that essentially Black individuals are statistically without risk. That we can't, that we can't rule out the fact that they don't go on to commit any new crime. And so what do we conclude from this? It means that judges have a relatively lenient bar for white individuals. They're letting out people who are still quite high risk, but they have a much stricter standard for the Black individuals that they're willing to release. And so this tells us it's not just the accumulated disadvantage that individuals are bringing into the court system, that judges themselves are treating white and Black individuals differently. And this needs to be one of the places that we target if we want to increase equality in our system. Now, when we zoom in, we could ask, well, what types of judges are treating white and Black individuals so differently? I don't have a graph for it, but we actually find very similar rates of discrimination among white and Black judges. So at least at the outset, this doesn't seem to be a case of representation, at least again, among the subset of judges who we observe. Where we do see big differences is in whether this is a full-time job versus something that you do just part-time. So in many courts around the country, being a bail judge is something that you do 5 days a week, 8 hours a day. It's something you have a lot of experience with. Other parts of the country, bail judges just do this maybe a handful of days a year, and the rest of the year they're working in other parts of the criminal justice system. Where we see this discrimination get incredibly large is among that set of inexperienced judges. So among the judges who are relatively new to the job or don't do this very often, we see much larger white-Black differentials that can't be justified by anything that we see in the data. Now that's only suggestive, but that tells us that this could be related to the inaccurate stereotypes and implicit biases that many of us bring to decisions. That when we're in a rushed or information-poor environment, that we lean back on these unconscious biases that we might have, and that leads to these incredible differences in how we're treating white and Black individuals. So based on this, along with my colleagues, we're trying to tackle these problems directly. And we're trying to partner with courts from around the country to improve decision-making generally, but especially to reduce these racial disparities. And so we're trying to do that through 3 cost-effective and evidence-based interventions that we've drawn from other settings where there seems to be some promise. And critical to our earlier work, we're really trying to tackle a key stage of the decision-making process where these cognitive biases or errors can occur. So we're taking as given that perhaps people are just rushed, they're relying on inaccurate stereotypes, and let's try to target those in an effort to reduce these racial disparities and lead to better decision making on the part of judges. Now, these are just hypothetical materials, so this isn't from any particular court system. Each one is tailored to the court system we're working with. But the first intervention is just correcting the mistaken beliefs that many judges have about the underlying level of risk of white and Black individuals. So again, this is completely hypothetical. It's not based on any actual data, but we would show judges in each jurisdiction the actual differences in risk, which tend to be quite small. 2% would actually be on the large side of what we see. We often see no differences, versus what would have to be true to justify their decisions, which often are much, much larger. And this is just making the overall point in hopefully a very simple and straightforward way that judges are acting as though individuals are dramatically different, when in fact the data can't support that at all. The second type of intervention that we're bringing to the court system is just asking judges to slow down and be more consistent in their decision making. One of the real problems within the pretrial system is that judges only have 2 or 3 minutes to make these decisions. Despite the fact that they're so important for defendants, these are incredibly rushed decisions where often there isn't a systemic way that they're making decisions time after time. That's exactly the type of setting where our unconscious biases and implicit biases can really drive our decision-making process. So working with the judges, we're designing a checklist where they can make sure that they remind themselves of the key characteristics of each case that they want to consider. And if there's other factors that they think are particularly important, we're asking them to write them down to just be more consistent in how they're treating individuals. Now, this is not race specific, unlike the first intervention, but the idea here is just to be more consistent and to remind yourself to focus on the key characteristics of each case and not just rely on those unconscious biases that might immediately pop into your mind. Finally, and I think most importantly, is we're trying to give judges individualized information on what's actually happening in their courtroom. One of the things that amazed us when we started working with bail judges is that none of them had any idea what was going on among the individuals that they were seeing. So they didn't know how many people they were releasing, and they didn't know what happened after people were released out into the system. And so it's very, very challenging for them to actually correct their mistakes or even know that they're making mistakes. And so we're simply giving them the information so that they can see exactly what's happening and they can adjust accordingly. So again, this is hypothetical. This is not based on any actual judge or any actual court system. But the idea would be that we could show them, in hard numbers for the first time, that they're releasing far more white defendants than non-white defendants. And yet, there may not be very large differences in the actual levels of misconduct among those individuals. Now, in addition, we'll benchmark how individuals are doing versus the most high-performing judges in a court system, as well as what's possible. And so what we tend to see, perhaps not surprisingly, is that there's many judges who not only release fewer people, they have higher misconduct rates than other judges. That's what that is telling us, is that people just aren't identifying the right people to release versus detain, that they're just not very good at this process of discerning risk. And by giving people this data, we're going to hopefully help them move to this better level where they can release more individuals without changing their misconduct rate. And then finally, we want to help people see how their improvement is going over time. Again, it can be very hard to maintain changes over time. We all want to slip back into the way we've always done things. And so we want to provide that positive feedback that hopefully our other interventions will create. So for those of you who own a home and might have utility bills come every month, this is reminiscent of the interventions that have been designed to help people cut their electricity usage. It shows you not only how are you doing versus other neighbors in your area, but also are you getting better over time? And again, that's some of the inspiration that we've drawn from these trials. So we're currently live in 2 to 3 courts around the country, with another 3 courts scheduled to go online later this year. And the hope is in the coming months and years that we'll get evidence about what types of judges are helped by these interventions and what types of judges maybe need something else so that they can improve and have lower racial disparities. So again, I know this is just a small piece of the puzzle, but we're very optimistic that these types of interventions can contribute to the broader set of policies that are going to be needed to reduce racial disparities, not only in the criminal justice system, but in the American system writ large. So again, thank you so much for having me, and excited to answer questions.
Dr. Dobie, thank you very, very much. At least for me, very enlightening. I didn't know many of those things, I must say. Decisions to be made in 1 or 2 minutes it's just amazing indeed. I invite again questions on the Q&A, please. If you have questions, put them there. One of the questions is, Dr. Dobie, you presented some data for the Black population. What about Latinx population of other people of color?
It's a wonderful question. The answer, sadly, with much of criminal justice research is it depends on the jurisdiction. So in some jurisdictions, we do have information on whether an individual is Latinx or not. But in many jurisdictions, that information is not recorded, unfortunately. And so what we're doing in practice in our intervention materials is if possible, we're splitting it out into non-Hispanic white, Hispanics, and non-Hispanic Blacks. And we're also letting each court system tailor the groups kind of specific to their context. But again, unfortunately, this information is only available in some jurisdictions.
Thank you. You mentioned, perhaps you can unshare, you mentioned the 3 interventions in judges, and you particularly, you emphasized also the possibility of unconscious bias. But is there evidence actually from your studies that there is very systemic racism, and there clearly is not unconscious, but other types of bias?
It's a great question, and certainly historically, we know that the judiciary had a lot of explicit bias, and I think it would be naive to think that there's not judges who harbor explicit biases. Unfortunately, we don't have great research on this particular topic. We don't have, for an example, implicit association scores for judges or measures of explicit bias among judges. Now, people have done some work looking at legal opinions and trying to derive what they can from the text of those opinions. But again, that's limited to certain types of courts. One of the things that we're going to do along with our interventions is actually administer a survey. And in that survey, we'll ask for the first time for these judges to complete implicit association tests, as well as answer questions about explicit racism and explicit biases. So our hope is that that'll be one of the side benefits of the work we're doing with these judges, is we'll be able to shed light on exactly those types of questions for the first time.
Thank you. Thank you very much. See whether, do you see, is a question, do you see any notable differences at the intersection of race and gender, Black women versus white women?
It's a terrific question. I think here is where the quantitative work is perhaps less valuable than the qualitative work, simply because there are many fewer women in the criminal justice system than men. And so, for better or for worse, a lot of our interventions do skew towards the male population because they're disproportionately represented in the criminal justice system. I think there is great work. Again, I'm less familiar than I'd like to be, coming from people like Sandra Smith at the Kennedy School, exploring exactly those types of intersectionality issues. But again, it's something I think we need to do more on, but the quantitative work has been more limited than I'd like, just because there are so many fewer women in the criminal justice system.
Yes. May I ask a question? I know you focus on the criminal justice system, but I cannot resist asking, do you also have work on law enforcement? What, about a year after George Floyd? Can you say something about that?
Absolutely. I suspect, I don't have hard evidence on this, I suspect the types of interventions that will be successful among judges may not translate to what's going to be successful among police, to be honest. I think that the types of challenges that the judiciary face are a different set of challenges. And so I think there's wonderful work happening behind the scenes with the police and thinking about how do we both change the structure of the police, how they're represented, what are the policies and regulations and incentives of the police, as well as different trainings and along those lines. But I do suspect it's going to be quite different than the judiciary. And I think that's, probably of even more importance than working with the judiciary because of all of the horrible events that we've seen over the past several years.
Dr. Dobby, thank you very, very much. Greatly appreciated your contribution. Thank you. We go to our final speaker, Professor of Social Epidemiology, Dr. Nancy Krieger, who is also in the Department of Social and Behavioral Sciences. She is a major social epidemiologist, and the title of this symposium, of course, is Epidemiology and Racism. And Nancy, wonderful to have you. Epidemiology, structural racism, and the two-edged sword of data. Structural problems require structural solutions. Dr. Nancy Krieger.
Thank you very much for including me. Let me share my slides. Great. So as I would like to begin, as I do all my talks, by acknowledging that as a US person in Boston, I'm on Indigenous land and I pay heed to critical Indigenous thinking. I also speak at a time of renewed hope to address the continued outrage, grief, and social mobilization over structural racism, police killings, and assault on democratic rule, which are all profoundly intertwined with COVID-19. I'd also like to acknowledge up front that as one of 2 white speakers on a panel that has 3 people about racism and health, I draw on over 2 centuries of work by anti-racist scholars, including, but not only, myriad scholars of color. My starting point is to affirm that anti-racist and anti-essentialist science is essential. The point of analyzing scientifically how racism harms health is not to prove that injustice is wrong, because it is by definition, nor is the point to do quote unquote politically correct science. Rather, the point is to do correct science, to generate publicly testable and tested knowledge that provides insights into who is bearing the burden of exposure, disease, and death, and to ascertain if these distributions are inequitable, whereby health inequities refer to differences in the distribution of health outcomes across social groups that are unjust, avoidable, and in principle preventable. Also to underscore, work on racism and health is not a quote unquote niche issue. Considering only the US, persons of color comprise 40% of our population. Evidence abounds as to the ubiquity of self-reported experience of racial discrimination and the impacts of structural racism across all domains of what are now termed the societal determinants of health, per what my colleague David Williams has just described, involving where we live, work, play, love, ail, and die. Stated another way, in racialized societies, good luck finding health outcomes that don't manifest racialized health inequities. Indeed, galvanized by this past year's relentless exposés of and organizing to confront social and health injustice, both NIH and CDC have finally explicitly stated that structural racism is real and a serious threat to the people's health, and they're investing new resources to deal accordingly. Mind you, these unprecedented statements should not be controversial, as these two facts have been self-evident to and documented by those not protected by racial privilege, and also by any serious scholar of the people's health. But of course, to comprehend, analyze, and guide action to rectify these inequities, these facts require theory. On the slide, I show the overall framework of the ecosocial theory of disease distribution, which I first proposed in 1994 and have elaborated since, and also its direct analysis of racism and health. Concerned with levels, pathways, and power, and also time in relation to both individual life course and historical generation, ecosocial theory seeks to explain population distributions of health. A central focus is on embodiment, referring to how we literally incorporate biologically our societal and ecological context, thereby producing population patterns of health and health inequities. The theory clarifies that there are many pathways by which structural racism harms health, including but not only economic and social deprivation, excess exposures to toxins, hazards, and pathogens, social trauma, health harming responses to discrimination, targeted marketing of harmful commodities, and both ecosystem degradation and alienation from the land, especially but not only for indigenous peoples. The ecosocial constructs of agency and accountability further clarify that racism, not quote unquote race, is causally what's relevant and is diametrically opposed to the dominant view, which draws the arrows from quote unquote race to racial differences in health status and culture, see the problem as one of alleged biological and cultural inferiority rather than white supremacy, and the privations imposed by the privileged to protect their wealth and status. Reckoning with health inequities requires reckoning with embodied histories and structural racism. A rigorous and anti-essentialist science, and thus an anti-racist science, likewise requires reckoning with who wields the two-edged sword of data. A crucial first point is that data is, contrary to its etymology, never a quote-unquote given. Despite being the past participle of the Latin verb dare, to give, data are always produced by people, revealing what they observe, fail to see, or suppress. A key sticking point to remember is that privilege is always defined in part by who and what you can afford to ignore. Another is the essentialist racist assumptions that have been contested ever since they were first espoused, meaning that the excuse that, quote, that's just the way people thought back then, was not and is never acceptable. One accordingly must always ask who produces and controls the data, to what end, and engaging with what history. For the US, histories of contested production and use of racialized data extend back to origins as a slave republic and settler colonial nation. Here, given lack of time, I will simply flag that these data were first produced and used in the 18th century CE by the enfranchised minority of white men with property to entrench injustice, to characterize who was enslaved versus free, and which indigenous tribes and nations were versus were not under colonial and then federal jurisdiction. Their use became increasingly contested in the 19th century CE as abolitionists, including the first generation of credentialed African-American physicians, began to contextualize racialized data to challenge slavery, and also it was used by its supporters, including proponents of scientific racism. Next were the 20th century contestations involving use of racialized data, both to oppose and support the Jim Crow regime of legal racial segregation backed by terror, and the same held for eugenics, an ideology that was upheld by the US Supreme Court and leading scientists, university presidents, including our own, politicians, and more, one which led to the passage of eugenic sterilization laws in 32 US states, and also the Immigration Restrictions Act of 1924 and 7. That in the wake of major legislation won in 1965 that afforded new protections of civil rights and expanded immigration, use of official government data in the US on race ethnicity shifted started to providing evidence of injustice as opposed to justifying it. However, the successful civil rights strategy of using racial ethnic data to demonstrate the existence of what was termed statistical discrimination or disparate impact sparked, unsurprisingly, a conservative backlash, leading to two types of resistance. One was to try to suppress collection or reporting of racial ethnic data. The other, in legal cases, was to require evidence of motivation, not just disparate impact. Hence the two-edged sword of racialized data. In societies with deep histories of structural racism, not to have any racial ethnic data, usually couched as a quote unquote colorblind approach, leads to the problem of no data, no problem, and denial of and inability to prove that the problem exists. That's edge one of the sword. Edge two is that problematic data, whether wrongly conceived, wrongly used, or both, can also be a big problem. And meanwhile, keep in mind the actual point. What are the data needed to secure health justice? Let me share two illustrations now of how the two-edged sword of data can cut deeply, causing deep harm, for what I presented at the first meeting of the Federal COVID-19 Health Equity Task Force this past February. First, edge one, no data, no problem. During the first terrible months of the pandemic in the US, you could find barely any government COVID-19 data by race ethnicity, despite it being a standard variable for just about every other health outcome. Instead, in this early period, so crucial for understanding and altering the course of this pandemic, data journalists led the way in piecing together the evidence, illuminating both data gaps for and greater burdens among populations of color. In response to public outcry on June 4th, a new regulation mandated reporting racial ethnic data by no later than August 1st. However, on September 16th, my team and I checked the CDC website and found that racial ethnic data were still missing for 43% of the COVID cases added between August 28th and September 16th. We checked again in early February this year, and for cases reported between December 2nd and February 3rd, fully 33% were still missing these data. Worse, on February 1st, CDC reported that racial ethnic data were missing for 48.1% of persons vaccinated against COVID-19 in the first month of the rollout, which was from mid-December to mid-January, but only 0.1% and 3% were missing data on age and sex. And despite continued public outcry, as of this May 10th, these racial ethnic data remain missing for 40% of persons who have received their first shot and 34% of those fully vaccinated. Moreover, the continued lack of economic, occupational, community, or other textual data on government websites leaves the decontextualized, racialized data open to narratives of victim blaming. Moving on to edge two, the initial response of the CDC to the outcry about missing racial ethnic data was to focus on proportions, not rates, comparing the racial ethnic composition of COVID-19 deaths versus those of the total population. But the data on their website at first made no sense, because contrary to the reports coming from the field, the CDC data indicated that the white non-Hispanics were overrepresented and that Black Americans were underrepresented among the COVID deaths. Working with some doctoral students here to figure out what was awry, we realized that the CDC had committed a classic type 3 error, right answer to the wrong question, as we demonstrated in our publication last July. In brief, the CDC weighted denominators for the US counties by the percent of total COVID deaths occurring in that county within the state. Given who was hardest hit by COVID, the net effect was to deflate the denominators for the white non-Hispanic population and inflate the denominators for populations of color, respectively inflating and deflating their risks. CDC's stated rationale was that this racial ethnic composition of places initially hit hard by COVID differed from those of areas hit less hard, and they sought to quote unquote correct for this by waiting. But to ask and answer the question of how does racial ethnic risk for COVID-19 mortality vary apart from how racial segregation affects who lives where is to ask and answer the entirely wrong question. By treating placed and lived experiences and impacts of residential segregation as nuisance factors to be quote unquote corrected for by waiting, the CDC reached the entirely wrong conclusion. Partly due to criticisms raised late last summer when briefly could find a single table that included both the weighted and unweighted population data, which was then replaced by a figure showing case data only. This March, however, a new single graphic has appeared showing the unweighted racial ethnic composition of both cases in the population, courtesy of the new administration. Were these data problems inevitable? No. Plenty of studies by my team and others have reported more or less in real time COVID-19 outcomes by diverse social metrics, including racialized economic segregation at the county, city, town, zip code, and census tract levels. And we've produced new data on educational gradients and COVID-19 mortality within and across US racialized groups. To that meeting, then, I would propose that COVID-19 data should first always reveal racialized economic health inequities in real time, and second, should always be presented jointly by racialized and economic groups, along with age and gender. Beyond this, looking at the bigger picture, I propose that structural problems require structural solutions. Goodwill is not enough. What I suggested, elaborated in an article published this past April, is a feasible two-part enforceable institutional mandate. Part one is that all US health data sets and research projects supported by government funds must explicitly explain and justify their conceptualization of racialized groups and the metrics used to categorize them. Part two is that any individual health data by membership in racialized groups must also be analyzed in relation to relevant data about racialized societal inequities. There is precedent. Consider only the 2014 NIH mandates that all grants must quote unquote address quote unquote sex as a biological variable, even as this mandate remains silent about gender. Failure to comply affects the grant score. This can be done. Or for a more dramatic carrot and stick example, consider the case of desegregation of US hospitals. Between the passage of the 1964 Civil Rights Act and the implementation of Medicare in 1965, in 11 short months, the AMA and the vast majority of US hospitals ceased supporting racial segregation, and they actually began managing to desegregate, because if they didn't do that, they wouldn't get Medicare funds. Also needed is data equity-oriented work on data governance, that is, who has input into making decisions about which data are required, informed by the tandem expertise of health equity researchers and other members of communities whose data are at stake, affording the expertise of lived experience. Continuing with the status quo is not acceptable. Nor are there a lack of relevant metrics to implement this proposal. This conceptual schema that I developed for my 2020 annual review of public health article delineates many types of structural and individual level measures of racism and other forms of injustice that are used in research today. This is absolutely feasible science right now. And as for what happens without structural requirements, consider our new analyses in Health Affairs blog, which we just published along with the popular version in Time magazine. To wit, of more than 200,000 articles published over the last 30 years in the New England Journal of Medicine, The Lancet, JAMA, and BMJ, less than 1% included the word racism anywhere in the text. And most of those that did were opinion pieces, not scientific studies. Demonstrating, however, that the science is there, American Journal of Public Health, despite publishing fewer articles in total, published many more using the word racism, of which fully 40% were empirical papers. We also located 140 reviews in the annual review series that pertained to racism and health. Evidence, therefore, exists. For today, I also did a quick check on the International Journal of Epi and the American Journal of Epi, and while they resemble the medical journals for the low percent of articles that include the word racism, at least they are closer to the American Journal of Public Health for the percent that are empirical investigations. Why does this production of scientific ignorance matter? 4 reasons, among many, are that first, the lack of publications conveys the message that racism and its health impacts are not important. Second, it fosters ignorance among clinicians and the broader public about racism and health. Third, it limits evidence for policymakers and advocates. And fourth, it excludes and penalizes scholars who focus on racism and health, thereby potentially affecting their career trajectories and harming academic inclusion. Last year, the University College London removed from all public places the names of Francis Galton and Carl Pearson. Galton famously coined the term eugenics and endowed the first chair of eugenics at the UCL, which was occupied first by Pearson, the highly influential biometrician, think only of the Pearson correlation coefficient, and who heartily embraced eugenics. Then on January 7th this year, one day after the armed anti-democratic white supremacist assault on the US Capitol, UCL released not only a profound apology for its past support of eugenics, but it also included the pledge, quote, to continue to confront its history of eugenics and ongoing legacies openly and critically, and to ensure that UCL staff and students are enabled to do the same, end quote. I, for one, teach about racism, eugenics, and health in all of my courses that deal with epidemiology and the people's health, but most epidemiology courses and programs don't, and they should. So in conclusion, we live and die embodied. It is essential to use anti-racist and anti-essentialist science to confront this two-edged sword of data so that we can correctly monitor and analyze inequitable burdens of exposure and adverse outcomes so that all the different sectors, government, private, civil society, can know who is most harmed, who is responsible, and in many cases benefiting from these inequities. Only with such embodied truths, backed up by possibilities of lawsuits, legal accountability, and social movements organizing for social justice and changes in policies and regulations, do we stand any chance of making headway on the twin tasks of protecting the people's health and advancing health equity. And no matter where we reside, let us do our work informed by history and a vision premised on social justice and human rights, along with deep recognition of our interconnection with and dependence on our wondrous and threatened planet. Thank you.
Dr. Krieger, thank you very much. This was eloquent and forceful, not unexpected, I must say, but it was great. Thank you very much. I again invite questions in the Q&A, but I would like to start with one myself, if I may. You mentioned this two-parts proposal, huh, on health data. Can you elaborate a little bit on that? I thought it was very, very interesting.
So one, again, is that the first part is that if people are going to use racialized data, which in the United States is impossible not to, in terms of if you actually think about who the population is, you actually have to explicitly explain what you're doing. There are journals that do request this, but it's not required, and it's certainly not, I mean, I get asked for review for a zillion different kinds of journals, and they don't tell you, the reviewer, that you have to pay attention. So this is partly about, if you're going to do the science and you're going to get funded to do the science, you actually have to be very explicit about how you're defining who the people are in your population. And it's easy to give many examples of where this is done either A, not at all, or B, horribly. The second point is that if you're going to work with data that has individuals as members of social groups characterized in relation to their racialized social group, it has to be in conjunction with data that show what the racialized inequities are in the society. The examples that you saw in the data that, for example, David was showing earlier at the beginning was, for example, always linking the racial ethnic data to income data or other measures of socioeconomic position, but also not just the individual level, but the contextual data in terms of where do people live and is there residential segregation, et cetera. So this is doable and it can be required, and it can be something that can be scored in grant applications for grants. And it can also be mandated that if health departments are going to report data on their public websites about their population, if they get government funds to do this, they need to do this as well.
Nancy, thank you. Any question? Let me ask then the last question, and we have a minute and a half, but it's University College in London. Carl Pearson, Francis Galton. What about Harvard University?
There is an active commission they came and spoke to our Harvard Chan faculty meeting a few months ago that's looking at these questions of what to do about places in Harvard. We have terrible legacies that need to be confronted, and a plaque doesn't do the trick. That's been really shown. So the two names that are, I mean, one that's extremely prominent is that obviously of Louis Agassiz, whose name is plastered onto many different buildings. He was a 19th century biologist who was profound supporter of and progenitor in many ways of scientific racism. He came from Europe to here. He was initially from Switzerland. He came here. He had an abhorrence of people who were Black. It's expressed vocally in his writings. And he was key to institutionalizing scientific racism and working with people that were actively defending the existence of slavery based on the assumptions of fundamental innate biological inferiority. So he's somebody who, for example, Cambridge, the school system already has removed his name from one school. I think that if you remove names, you need to have public explanation and have public reckonings with that. I could go on and give the list. For example, again, Harvard's longest serving president was an avid supporter of eugenics and was key to the Immigration Restriction Act that was passed in 1924 and 27. There are many other examples. And actually in my course that I teach in the fall, I assign the examples about the support here. Also other universities, Stanford, they've had to remove the name of their first president from buildings because he was absolutely outright eugenicist, supporting all kinds of egregious policies.
Dr. Krieger, thank you very much. Really impressive. May I thank Dr. David Williams, Dr. Will Dobby, and Dr. Nancy Krieger for this great symposium. May I also mention to you that after this, in about 14 minutes, there will be the start of the 172nd Cutter lecture. And on the chat, if you know what to get the chat, Coppelia, yeah, here it is. Copelia has put, by the way, organized this so wonderfully, congratulations and thank you, has put a link to the Qatar lecture because we think quite a number of people may want to go from here to there. But you have to have a separate link to that. With that, I thank you very much. There